ദൈവങ്ങളെ അനുവദിച്ചു. നന്ദി. ഇന്ന് അവിടുത്തെ ദാസനായിട്ട് ഡോക്ടർ ചിത്രയ്ക്കും ഡോക്ടർ ജയിക്കോയ്ക്കും വേണ്ടി പ്രാർത്ഥിക്കുന്നു. അവർ ഇവിടെ അവതരിപ്പിക്കുന്നതായിട്ടുള്ള കാര്യങ്ങൾ മനസ്സിലാക്കുകയും അതനുസരിച്ച് മുൻപോട്ട് ഞങ്ങൾ യാത്ര ചെയ്യുവാനും അത് ഞങ്ങൾക്ക് ചുറ്റും ഉള്ളവർ ഞങ്ങളെ കാണുവാൻ വരുന്നത് കേൾക്കുവാൻ വരുന്നത് എല്ലാവർക്കും അനുഗ്രഹങ്ങളുടെ സഹായം ആദ്യം നമ്മുടെ ഈ മീറ്റിംഗിൽ
Thank you, Achin. Before we start our formal session in association with the observance of the World Mental Health Day, we have a very happy news to be shared with the floor. And I invite Dr. Ria to come forward and talk about that in detail. So she's going to basically speak about the Young Innovators Program, and she's going to announce the statewide winners of the same.
Thank you, Dr. Suman. So good morning, everyone. So before we announce the winners, I just like to give a brief context on what this is about. So Kerala Development and Innovation Strategic Council, it is the think tank of the state government, and it is committed to fostering innovation and creative problem solving across Kerala. Its flagship initiative is the Young Innovators Program, and they envision empowering young minds with the skills, knowledge, and support needed to become innovative problem solvers and change makers in society. So we are delighted to share that in the Young Innovators Program version 7, which began with 8,614 teams last year from across the state and different various academic sectors, 7 teams represented our institution. And among them, one exceptional team advanced to become district level winners with the innovative footwear design for diabetic ulcers, and now have emerged as state level winners along with 22 outstanding teams across Kerala. At the district level, they received a cash prize of 25,000, and at the state level, they have been awarded a cash prize of 50,000. The state now will be organizing mentorship sessions and product development support for these winning teams. And adding to this achievement, Believers Church Medical College Hospital has been recognized as a top state institution, securing 3rd rank in the innovation sector. This is a very significant milestone for the student-empowered Helix Innovation Club, who have already made a milestone last year, achieving rank 14 in the National Entrepreneurship Challenge by IIT Bombay. So now I take great pleasure in inviting Jochandi sir, who has always extended an unwavering support to this club, to felicitate the state level winners of the Young Innovators Program 7. So our winning team, I call Anne Serena Wilson, MBBS batch of 2019, and Sri Lakshmi Pradeep,
a big hand.
MBBS batch of 2021. And their official mentor is Dr. Philip Matthew.
Congratulations. Is Philip here?
Philip, sir.
So we'll have a quest where they will present. Last night we had over a meal, we talked about all that, their journey. And it's really inspirational. So it will be good for all of us to listen to all that happened. But just for today, on behalf of all of you, I will congratulate them. We'll give you voice very soon. Over quest. These are our very own students, and the only medical college amongst these, the winners. The only all the others, as you would guess, are all engineering colleges. We are the only medical college, so congratulations. I want to just introduce to you 2 very special people who are here with us. One is Mr. Sunny Kuruvilla, who made Baptist Hospital a national special mission center full of ideas and knowledge. And I'm hoping that he'll translate all that here. He helped 2013 to 2015 to establish this institution. After 10 years, he's come back to check whether I've done all the right things. So please welcome Sunny Kuruvilla. I have a very special friend. Her name is Rita Carolyn Isaac Aaron. She's a MBBS MD from CMC Vellore, MPH from Tufts University. What the very special thing she did in CMC was to develop and build up what we call the Rural Unit of Health and Social Affairs, RUSA. One of the components of our community health department was a adjunct professor in the Department of Public Health and Family Medicine at the Tufts University, a research star. Who are the research people? Be excited. Lots of collaborators from all around the world. And she's joined us in the Department of Community Health. Welcome, Rita. Thank you to have you.
Thank you, dear sir. So now I invite dearest Jaico sir to introduce the speaker and to make the introductory comments for our session.
Respected seniors and dear friends, it's a great honor and privilege to introduce the speaker of the day, Dr. Chitra Venkateswaran. She is the HOD of the Department of Psychiatry, Believers US Medical College. But beyond the shores of this institution, beyond the shores of this country, she's an internationally recognized palliative psychiatrist, among the top 10 in her field. Her list of achievements is almost endless. So if I were to list out the whole thing, there would be precious time, little time left for the presentation as such. So I'll just focus on the main things, madam. Please forgive me for leaving out some. Madam worked as a WHO trainer and mentor for palliative psychiatric services in the country. She is a UICC research fellow, where she worked in the UK for 2 years. She has finished a leadership initiative fellowship program from Ohio Health. She's a Bernard Lowndes Scholar in Cardiovascular Health, Harvard, T.H. Chan School of Public Health, Boston, USA. She has finished an advanced course in licensed psychiatry from Manchester in 2002. She has worked as and is currently working as a principal investigator and a co-principal investigator in numerous research programs funded by the ICMR, the Harvard School of Public Health, and many such esteemed institutions. She was an invitee and she has delivered a TED Talk in 2022, TED Talk India, on her experience in palliative psychiatry. But above all this, she is admired for a work that she has done in our community. After she passed her MD, unlike many others, unlike many of us who have opted for more lucrative opportunities in private psychiatry and in medical colleges, ma'am chose to follow her heart, because she recognized that even in a state like Kerala, which prides itself as a place where mental health services and generally health services are freely available to people, there are marginalized sections in the community who don't even reach the doorstep of medical health care. So she decided to go to them. For this purpose, she started her own NGO, Mehak Foundation, in 2008, with the aim of delivering mental health care services at the doorstep of the marginalized people, the tribals living in the inlands of our country, the rural folk in the coastal regions, the underprivileged sections of society who never managed to come seeking help to the mental health services in our country. And now this NGO was started in 2008 and it's currently running for the last 17 years. And because of her exceptional leadership skills and her inspirational style of working, she has managed to find people to come and carry out the work. So she has now retreated into a mentor role. So madam, we are greatly privileged to have you with us. Thank you for being you, and I yield the floor for this presentation.
Good morning, everyone. Good morning, the seniors and friends and students, everyone who's come here in the morning. Thank you, Jaico, for that kind, description of my work. So what I present today will probably be taken from all my roles, like what we did in BCMCH, in Believers Church, in the community through Mehak Foundation, my partnerships with other organizations and palliative care. So I'll be talking about the importance of mental health in humanitarian issues, bringing out the need for it, as well as our own experience in terms of what we did during the crisis that we witnessed, and some recommendations. So it's about the theme of World Mental Health Day is about access to services, good quality care for people during catastrophes and emergencies. And what more time is more opportune for this, because we are surrounded by conflicts and issues these days globally. It's so distressing to see what's happening around the world. And the questions that come to our mind are, how are these catastrophes and emergencies affecting the mental health of human beings? Because we are witnessing a lot of suffering. And is there sufficient access to services to sustain, if not improve, mental health? Because as we all know, we are all human beings and we are emotional. We are rich in emotions actually, and we respond to situations. Suffering is rooted in the essential nature of human beings, especially in such crises. So when that's the essential nature, but in such crises, we need to mobilize other fundamental natures of human beings, our compassion, our need to be supported, to facilitate support, healing, and the care for others. So mental health and suffering is really very entwined with each other, because we treat the body a lot, but then the mind is part of the body, and we know that when a person goes through suffering, the mind is involved so much. And so there's expressions of collective loss. There's a loss of meaning. There is grief. There is blame. There is anxiety. Families are separated. There is poverty, homelessness. People are bewildered and lost amidst this complete dread of a catastrophe. And like we know, during the pandemic, there was this loss of contact also. We were so isolated, not able to offer presence or receive presence, even to the most vulnerable. So these are some recommendations which the WHO and UNICEF has come up with. It's called the MHPSS. It's a minimum service package for mental health and psychosocial support. I'm just introducing this concept because this is very important that we also plan this and prepare ourselves, so that that's the fundamental need in this context, the policies and the preparedness that we have as a team to address mental health, because mental health support in emergencies and crisis requires a major rethink. And constant exposure to this trauma, and also I think as healthcare workers, we are burdened not only ourselves during this, we suffer ourselves, but I think we give a part of ourselves to others. We take care of others in this extreme challenging situations. And that plays an immense burden on mental well-being of all the healthcare workers. So I want to emphasize on the healthcare workers' mental health or mental well-being also. The severity, why are we talking about mental health in this humanitarian crisis? Because whenever a crisis happens, we know that the acute emergency, the trauma services are very important. It's the priority. But are we really looking at mental health at that point? So what is the severity that we should know that mental health should also be a priority during humanitarian crisis? At least 22%, that is 1 in 5 people who have experienced war or conflict in the previous 10 years has major mental health disorders, like mood disorders, bipolar mood disorders, schizophrenia. The commonest are post-traumatic stress disorder, depressive disorders, and anxiety, which is actually reported at high rates, almost up to 30 to 40% in certain settings. And they're significantly influenced by the exposure to trauma and other factors like gender, age, discrimination, displacement, etc. The common emotional responses that we have, all of us, when we respond to a situation, we become sad, profound sadness, sleep issues, fatigue. All this is very common, and we can really identify with these emotional risks. They can improve when the situation or the context change. But for few who cannot cope or who do not receive support, it can develop to chronic conditions. So we have to be aware that even when we are looking at people with common emotional reactions, we need to identify those distress symptoms, signs, and then follow them up so that we can monitor and help them not get into these chronic conditions. And as we all know, the mental distress is aggravated by issues that we know. I'm just going through it so that we are reminded about it. Social factors like poverty and discrimination, separation of the family, lack of safety and security, loss of livelihoods, disrupted social networks, low trust, and reduced resources. And during a crisis, a conflict, there is overcrowding, lack of privacy, and undermining of community supports. There's a lot of factors in the society that actually aggravate mental health distress. And there are specific factors that are related to mental health issues as well as the services. Previous illnesses, there is quite a number of people amidst us who have mental illnesses. So the previous illnesses, mental health conditions like any disorder that a person can have, associated with loss and grief due to the crisis, stress reactions, and of course, substance use. You know that Kerala leads in alcohol use, isn't it? So alcohol use and other substance use, domestic violence, very common, and we noted that in the COVID-19 pandemic. Limited access to good quality, affordable mental health care. Mental health care, like Dr. Jaico mentioned, it's still, there is a huge gap, which we call as a mental health gap. When you look at WHO's guidelines, the mental health gap is very huge in low and middle income countries. And during a humanitarian crisis, there's damage to facilities. There is staff shortage, disrupted medicine supply chains, and surges in the demand because there's a high demand for these kind of services at that point. And this overwhelms the existing infrastructure. And of course, because of the crisis, there's a lack of coordination and there's insufficient training for emergency responders, especially in mental health care. People do not know how to respond when they go to see people during a crisis, what to say. They themselves feel helpless and they are at the wits to how to address this. This is something which affects us as healthcare workers primarily. That's why I wanted to bring this slide, burnout. This was mentioned and discussed a lot during COVID-19 pandemic, but I just want to mention it again. So burnout is very common otherwise also because we spend a lot of time, like I said before, we give so much a part of ourselves to others, to take care of others. So we suffer in that process and we don't realize it sometimes unless we, reach that point of burning, actually like a candle burning. So there are many concepts which come under burnout and you have symptoms like, emotional exhaustion. That is, you just feel that your energy is depleted. You are not able to carry forward. You're so exhausted. And you, in spite of doing also, you feel that you're not efficacious anymore. Your professional efficacy feels very low and accomplishment also. You don't feel that self-esteem drops and you also feel very negativistic. You don't feel happy. You feel very cynical about what is happening around you. There are many concepts under burnout that come up, discussed as moral distress. Moral distress was discussed very much during COVID-19 pandemic when there is, this is when the clinicians are asked how to carry acts which run contrary to their own beliefs, which involves ethics of justice also. Compassion fatigue, because of our relationship, how much we invest with the patient and the family. And of course, burnout stress with the work environment that we are involved in. Specific factors like stigma. Stigma as such is so rampant for mental health. When you go out in the community, you see that even now, even in a state like Kerala, we see when we go out, we see people who are chained and, shut in rooms and isolated from the family. And a family with mental illness, that family itself is isolated from other families in the community. They are not invited for marriages or any other social events because there is mental illness in the family. And this kind of stigma was exacerbated in COVID-19 pandemic, as we know. Like you see this lift where others are not allowed, when a healthcare worker was traveling in a building, an apartment in one of the urban cities. So people are labeled, stereotyped, and discriminated. They're treated separately, and this leads to a loss of identity and status for that person. And this also leads to distress and burnout for the healthcare worker. Suicide, I think we just celebrated the World Suicide Prevention Day recently, and this doesn't need much of function. We have been witnessing and seeing so many suicides, especially among healthcare workers, doctors. In the last 6 months, I think we must have lost quite a few number in Kerala also. So there's increasing reports of suicide globally. This also gets exacerbated, especially with social isolation, distancing as in COVID-19 pandemic, economic recession, mental health disorders as such, and the social boycott and discrimination. This is something we witnessed during the COVID-19 pandemic, the bereavement, the funerals, which were becoming, I lost a lot of family members, including my mother. And it was very complicated if there is a loss and the grief. It becomes very complicated because there is a change in traditional societal mourning process and there are strict guidelines. And I know that sometimes we have to witness the funeral or the cremation at a distance, wearing these equipment that the strict guidelines say. So this was something very, very distressing in that period. So this is just a brief overview of what we see during such humanitarian crisis in terms of mental health concepts. Now, I'll just touch through some experiences that we have. This is my experience also, because I'll be bringing in some work that we did in the community through Mehak Foundation, some with the partnership with governmental agencies like NHM, and then with palliative care also. So looking back, we have gone through a lot. As a state, we have gone through a lot. I'm not even talking about globally, but as a state, we have gone through the floods, which really kind of destroyed us. We can remember that in 2018, and then another one in 19. And then the tsunami of suffering, COVID-19 pandemic globally and in Kerala and in India. The Wayanad landslide recently, which took away so many lives and left so many, kind of stranded. There was so much of loss and suffering. And still we have continued suffering, pain and loss. We have the wars going on around us in Gaza and Ukraine, and we see so many losses, especially to the vulnerable population, to the women, the children, being bombed and killed every day. So what do we do? What do we do when we are faced with such crisis in our settings? So I believe that one way is partnerships, and that is how we have worked also. You work with other, because mental health is actually seen as, we cannot work in silos. You cannot work separately just as a psychiatrist and your team during such situations. We have to establish partnerships, collaborate with others to achieve more, to reach better to the people who need it. I work with, like Dr. Jaico said, Mehak Foundation. It's a not-for-profit organization. It is specific to mental health with community participation, and working, like we had worked for 16 years, and during COVID, we realized that we had really done enough work in the community in terms of preparedness, which is very important in crisis, because it helped us immensely in the crisis because of the network we created before the pandemic. We work with National Health Mission and the district agencies like District Mental Health Program, and of course with palliative care, with the teams I'm involved with regionally, nationally, and globally. So what did we do during floods? I was not working in Believers at this point. I came after the floods and joined in 2019. So this work was done mostly with Mehak Foundation as well as with the governmental agencies. What we did was run clinical services, capacity building and empowerment. We also did research. Every situation we face, we try to integrate research also, so that we can share some evidence, and that can lead to change in policies, and some, can pave way for education and empowerment. So research is always integrated. So we did a qualitative study to evaluate the psychological symptoms of post-flood survivors in Kerala. And the themes were predominantly on psychological issues and coping, with the themes that emerged while analysis. We trained around 2,100 participants, volunteers in the community, a total of 78 sessions with the National Health Mission of Ernakulam District between 2019 and 2020. And we partnered with DMHP, that is the District Mental Health Program, and the NHM to provide services in primary health centers during the floods in at least minimum of 4 panchayats in Ernakulam District. During the COVID-19 pandemic in Believers Church Medical College, we initiated helplines and developed a strategy to have teleconsultations and face-to-face consultations with protective gear whenever required. We also carried 2 research projects. Both were very important. As a co-principal investigator, we were part of the ICMR National Task Force on Mental Health and Social Stigma. So we studied about mental health and social stigma among healthcare personnel involved in the management of COVID-19 patients in India. It happened across India, and we were part of the team. I'll be showing the publications also. And Dr. Abarna in our team carried out a survey in general population to look at depression, perceived stress, and socio-demographic correlates during COVID-19 pandemic. We also really emphasized or prioritized support for staff during emergencies, opening our services for them to drop in whenever they wanted because of the burnout concept, and we knew that people were going through a tough time. And recently we partner, Dr. Ria led this, we partner to run the Mind Matters Well project, which is again for healthcare workers and students. So these are 2 publications, important publications of the ICMR study, the National Task Force, where we looked into psychological distress and burnout among healthcare workers. And we got the evidence that 52.9% of the participants had a risk of psychological distress, and almost 10% had burnout. So that was what we got, and it's a significant number that is going through stress. Aparna's study on depression, perceived stress, and socio-demographic correlates, of the 600 subjects who were enrolled, 26.7% had, 15.7% and 9.3, all good numbers have depression, mild to moderate. And 62.7 had moderate and 17.5 had high perceived distress. And there were 28.7% of people had death wishes or thoughts to hurt themselves. Remember, I mentioned about suicide. So quite a significant prevalence of distress when we see such studies. As part of Mehak Foundation, when we were doing the community work, as I said before, we work with partners in the community. We work with panchayats or primary health centers. We work with other non-profit organizations, institutions, hospitals. We partner with anyone and offer the expertise of mental health care, running services, empowering the community, doing research. So there's a multidisciplinary team that goes into the community proactively, and we do a lot of home visits for people who cannot reach mental health care. So it was a very smooth running process in the community, but the COVID-19 pandemic took us back. We didn't know what to do at first. But then we worked with the community, and we planned the clinical services very well during the humanitarian crisis. We had a good strategy, and that is when we realized that because we had worked before, the network that we had created was robust, and we could actually do a lot for people because of that network. And ASHA volunteers and community volunteers who were trained before, we also had a database of them. So they were involved in going for home visits. We didn't have to really go on a person. We used the WhatsApp video, and they also delivered medicines. And we had experiences where people with mental illness and their family members used to tell us, don't come this far, or you have to take care of yourself. We are safe, and we will call you if we need you. So such was the rapport and the trust they had in the relationship that we had. And we did home visits for emergencies. A helpline again was initiated immediately by Mehak, and we partnered with the COVID Nodal Center in Ernakulam district to provide services again. We again published a paper in Frontiers in Psychiatry, where we wrote about how we reimagined the community mental health care services during the COVID-19 pandemic. Partnered with palliative care. Palliative care is very close to my heart. I work with palliative care. I think Ligia is not here because she's gone for her work. But I work very closely with palliative care. And during the COVID-19, we also developed, like a group from Kerala actually, with help from international and national colleagues, developed a resource toolkit for low and middle income countries to train, support, and empower healthcare workers who were caring for seriously ill patients and families during the COVID-19 pandemic, focusing on the key issues where palliative care contributes as part of COVID-19, especially mental health issues. There was a lot of emphasis on psychosocial distress, and we could publish 2 or 3 papers regarding this in terms of an overview of psychosocial aspects of COVID-19 in the context of palliative care, and also this resource toolkit. I also work with CARDIS, led by Dr. Moira Leng, whom I think she's familiar to many people here, and I work with her in Africa also. So we did the mental health needs assessment in South Sudanese refugees in Uganda. So this is again another vulnerable group in humanitarian crisis for refugees. And we did a mental health assessment, and we presented this recently in the European Association of Palliative Care Conference in May in Helsinki. So the study showed that at least 92.4, that is majority, almost all of them had significant distress, moderate to severe in intensity. So what do we do at times of suffering? So I have said that there's a lot of suffering, there's mental health concepts that come up, what we did. But what can we really do? So I think we all believe that, and it's our slogan or motto also, that there should be compassion. Compassion, empathy is the values that we live with and we want to give others also. So to show that we are here for you, that is probably the primary belief and value that we should carry. But as healthcare professionals, as mental health care professionals, what do we do? Psychological first aid or communication and addressing emotional issues in challenging situations is very important. There is specific training modules for this, and we are planning, Dia and all the psychologists in our department have planned to start training the nurses on psychological first aid. So that is one program that we'll be mentioning tomorrow also, that we are going to do it in the next few months. So effective communication where you're being present, even for a brief moment in a hectic situation. How do you use your verbal and non-verbal skills effectively, exploring emotions as well? You preserve your dignity, preserve the dignity of the people you care for, show empathy and compassion in an effective manner. Ensure teamwork. Teamwork, I think, is absolutely important during a humanitarian crisis. You cannot work as an individual, you have to work as a team. And often, like I said before, the methods that we work during normal times, in inverted commas, normal is always, again, a gray line, but normal times, and when a humanitarian crisis strikes you, then you realize that you have to actually create new pathways. So you use innovation and creativity to develop strategies to address what you need to. Decision making, very important to establish goals of care during humanitarian crisis. So mental health care is part of decision making, and also establishing triage, appropriate triage, have anticipatory conversations, especially during end of life care. You have to have treatment consensus, communicate, documentation is important. So holistic care is very important, and there is no care without mental health care. And how do we establish a referral system for complicated and complex people? So this is one pathway that we developed for the COVID-19 pandemic for psychosocial interventions, and it's got published. So I believe that all systems should be integrated. We cannot work like, for emergencies, mental health has to work with other specialties and other teams to provide. So there should be an integrated pathway which is ideal and appropriate in our settings. Spiritual support, it comes along with psychosocial always. So we have to have meaning and purpose in our lives, but we give a lot, so we be the light for others. So this constant search for meaning, purpose, connectedness, and hope, which gets lost and demolished during humanitarian crisis. So emphasize on that. And how do we do that? You listen and offer presence. You facilitate narrative. So you listen a lot. You listen to what people want to say about their existential crisis. Have open questions like, where do you find strength or hope in difficult times? Respect the values and beliefs of other persons, and offer specific faith-based support. I think perhaps this is one area where low-income, strong community settings like ours demonstrate much more strength to high-income settings, because we have a very, we work together. We have joint approaches to everything, from family to the team that we work with. So I think it's very important to hold that. Home care, I think we do home care here in palliative care, but home care is actually also very important during crisis like this. And mental health care, again, has to be integrated with home care, because the emergency care can be provided at home. You reach people who do not have access, and you can distribute the essentials and medicines. You can empower and support the family and the community. You understand the situation real time. So people who come to the hospital as your patients, sometimes when you go home, you see that the situation is very different from what you imagine. It's very different. Or often when we go to the home, you see the real time situation of the person. And of course, I think home care is one of the best ways to address the stigma, that you are actually getting close to them, and you're actually showing a model in the community that it doesn't actually matter that you're going to a family with mental health issues. Most important, I suppose, because I'm talking to a group of healthcare workers and being one myself, is the staff support that we should actually have. So as I said before, burnout, compassion fatigue, and moral distress, very, very real issues, especially during a humanitarian crisis. So the responsibility is immense or important to care for ourselves and each other and our staff. And I think as leaders, we should seek justice for health workers' working environment, encourage rest and balance. We know that there's a lot of work during a humanitarian crisis, but how do we maintain a balance and provide spiritual and psychosocial support? Overall, I think it's a collective action leading to change that is important. So on tomorrow's World Mental Health Day, and I want to advocate. This is also about advocacy and awareness. So we need to really emphasize on global awareness and education, and have, just like we are discussing today, have more open conversations, because it's crucial to remember that stigma is even now in Kerala a significant barrier, and especially during times of crisis where mental health needs are often heightened. Advocacy and policy development, the leadership group should look at policies that prioritize mental health care even in the most challenging circumstances, and facilitate community engagement and workplace mental health. I'm ending my talk now. I'm open for questions and discussion. I would end with this statement by Aung San Suu Kyi. It was in 2013, but always remains close to me, because she says that the kind of innovative healthcare to look forward is to the one rooted in human values and spirituality. Do not look at healthcare innovation only in terms of technology, training, and medical education, but in terms of helping poorer societies and getting back to the basics, creating a healthy society. Healthcare is about caring, and without caring, healthcare will not have a meaning. Thank you.
Thank you, Chitra Madam, for that immense, rich, and dense presentation covering the topic comprehensively at a regional level, national level, and her work in the international level. I'm very sure you'll have a lot of questions in search for her. So now the floor is open for discussion.
Many doctors are attacked by the patients and the relatives recently, last day also. So we are actually, the Kerala population is consuming large amount of alcohol. Whether it is this aggregation is indirectly related to the consumption of the alcohol. By appearance, I presume that many of them are alcoholic or drug users.
It could be, sir. Thank you for that. I mean, it's probably again a humanitarian crisis, the epidemic of what we have as alcohol substance use here, especially in Kerala, and we see a lot of violence because of that. Often substance use is one of the factors. I can't say that it directly leads to violence, I mean to such situations, but definitely substance use is one of the important factors that can complicate the issues. Often we see that there's also a medical intern also lost her life a year back. That person was actually under the influence of alcohol and has had probably delirium and behavioral changes. So definitely it is important, and so indirectly we are also saying that substance use has to be really looked into seriously in terms of as a mental health issue. In Kerala, the consumption is very huge. We lead, I think, probably in India, and lot of mental health illnesses are associated with it. Like you can have depression, you can have other kind of illnesses exacerbated by alcohol use.
Chitra, the landscape of healthcare in the country is going to change in the next year, more so in Kerala.
Mm-hmm.
So thank you so much for an excellent talk and making us realize how important it is. And I'm so glad that we're doing quite a lot.
Yes.
But we want to do more under your leadership. How does this fit in with the changes that are going to come with corporatization,
Yes,
private equity, and the concentration on wealth creation through healthcare? So that again has come because of COVID. Suddenly,
yes,
the world has realized that there's a lot of money from the wealth creators. They don't call them wealthy anymore. Ambani and Adani are not wealthy. They are wealth creators. They are creating for us, is what they are saying. So what will happen? Because our whole healthcare is going to be squeezed. So where will all this fit in? At your level, are there discussions to try and understand this?
So I haven't actively discussed this, but I realize that it's a very important issue when you say, and I believe, because I'm a person, when I look at myself as a person working in the community, I think the situation will be worse for people in the community, because when you have these corporate hospitals and private sector kind of getting more and more, systematized into the society, how many of our poor families can access those and get effective care? And I think services like Mehak Foundation will have much more meaning. That's what I think. But since COVID, NGOs in India are finding it very hard to get funding also. So it's a dilemma actually to how do we maintain this balance, because in India poor are going to remaining poor, and it's going to get worsened with such new things happening in terms of wealth creation. So they are not going to get much help from these services. That's what I believe, sir, because you have people in Orissa and Bihar where people have to carry their dead relatives on their shoulders because hospitals, government hospitals do not have vehicles, and the private will charge a lot. So I think the poor will remain poor and get displaced further without getting access. And for us, it will be more meaningful and more needed that we provide more care in the community. That's a very simple answer. I don't have any strategy for that, sir.
My request is that in your discussions, could you introduce this
Sure, sir.
as a
I'll
very
definitely.
important topic? Because I talked about this about 6 months ago, but I didn't realize it's going to grab us so quickly.
Yes.
And it's now like a flood. It is just taking over. More than 50% of hospitals in India are already been taken over.
Yes, I realize that. Yeah. It's very, very important. And for a country like India, it's going to really, it's not good news for people who cannot afford private healthcare.
Good morning, ma'am. Ma'am, what is your view on psychoneuroimmunology? There is a term called PNI.
I'm not an expert, though I am I'm a senior in psychiatry, but I don't have new evidence on psychoneuroimmunology. I think Dr. Jaico will be a better person to answer that. For me, psychoneuroimmunology means that mind and body are connected very, very strongly. Yeah. So that means that all these things are very important, that we have to look at the mind of whenever we take care of a person. So even if you're going to treat a person in any other specialty, it is connected to the neuroimmunology or whatever aspect you want to connect. The biopsychosocial model is very important. So you can have scientific evidence to look at psychoneuroimmunology, but that means that you're looking at the person as a whole. There is the psychological framework which we have to give importance when you're looking at other scientific aspects of the person. Jaico, if you want to say something.
It's a well-recognized concept, psychoneuroimmunology, and probably the bridge would be stress. Stress can produce disturbances in the immune system. Stress can also produce disturbances in the psychological system. And you have conditions like autoimmune encephalitis where the person may primarily present with a behavioral problem rather than with a neurological problem. And stress can get to the basic functioning of a human cell, because it is even believed that oocyte health, because that is what leads to the embryo health. Oocyte health is affected by the stress profile of the mother. So if the mother is stressed for 6 months or a whole, you have poorer quality eggs, poorer quality embryos, poorer quality human beings. So if that can be the basic level at which stress operates, then it's no wonder that it can affect our mind functioning also.
The purpose of this question was because the information finally controls the emotion. So even in COVID outbreak, what happens, we used to see news that death rate is high. So usually death rate was high due to secondary cause rather than COVID itself. But population was thinking that that is because of COVID. Their stress went into so much high, which lead into them to get more prone to COVID. So purpose, if you are able to communicate this PNI to general population, I think most of the people won't know. So once we are able to do this one, so that the grabbing information is becoming, we are in the era of information. Like we are getting so much information, which one is right, which one is wrong, we don't know. So purpose to navigate with the next outbreak will be the giving the perfect information, which has to be believed, which has not to be believed. That can have little bit effect for us. That's what I believe, sir.
Yes, like I said, there is an information overload and miscommunication, lot of information which comes during such pandemics. And of course now because of social media and such, there's so much of, visual data also that you get. So people do get influenced by that. But then COVID-19 was a unusual or a unique experience for all of us. So all of us were stressed also, and it's not only people, and stress can affect you in different ways. It's not only about the information about the specific issue that, I mean, of course, it's very important that we look into it, but how do you apply to the community settings? That's a challenge in a country like India, because where people are not even able to avail primary care, care in all aspects, or primary mental care, how can we also bring out such nuances? Is very important. Thank you for the question.
Just to add on to what you asked, so because Philip Finisar is here, we had a patient who presented with repeated episodes of hypoglycemia. So she was evaluated thoroughly from all sides, medical sides. Nothing could be found out. So we started working together as part of liaison psychiatry. So we found that stress was a very important part of her presentation. So we treated it with pharmacological agents. We treated it psychologically with the help of Jacob sir. And after around 2 to 3 weeks, she was having repeated documented hypoglycemia, 30s, 40s. And after the inpatient care, she has never had such episode for the last 8 months. This shows the strong connection between our psychic process, the mind, and as Sir told, the cell. So it's so connected and it's so underrated.
I'm doing a research in the community as part of the Harvard Public Health, the Bernard Lawn Scholarship, and what we are looking into is the hypothesis that stress is a factor associated with hypertension as a primary factor. So what we are doing is we are training the ASHA volunteers to deliver a simple psychological intervention in the community. So that is one way you get possible ways of addressing the stress in the community where psychologists are not available. Psychologists are the hardest to get now after COVID-19 pandemic. So psychologists, you don't have psychologists in the community. So you train the existing task force to give specific interventions. So we are training the ASHA volunteers to give interventions for stress, and then we'll measure all the biological variables. So that is one step we have taken to address that. And it's for people because this Paulose program is for cardiovascular health, but it's for hypertension that we are doing. So it's another way that, again, it's on the hypothesis that stress is primarily one of the factors which can influence or impact on hypertension.
Thank you, ma'am, for that excellent talk.
Thank you.
I just want to mention that every day in my endocrine clinic, whether they are thyroid nodule patients or diabetes, 30 to 40% don't have a major issue with endocrine. Most of them are dealing with stress and problems, and they break down and cry. So I wish I could have a little bit more support in terms of training sometimes, how to care for them, because they will not come to the psychiatry OP if you refer them. So I remember Dr. K.S. Jacob in Velo used to teach us that almost 40% of the patients in the medical OP sitting have psychosomatic illnesses. Only 60% have an organic medical problem which needs treatment. But some sort of a support service, we don't want to call it some psychiatry name. If there's a stress management clinic, even Chitra was telling me the other day that in this Mind Matters clinic, not many people want to come. So how do we break that barrier and enable them some sort of a name where we can get them to be well, because I don't have the time in my OPD to see, and many of my colleagues, sometimes I hear the patient tell them, I was told nothing wrong with you, cardio, go somewhere. So then the patient is left high and dry. So how can we support that cohort?
So what we did, this issue, I mean, this is a very common and very known issue in health, I mean, like when we work together. And of course, I understand that there's a stigma even to come to psychiatry, stigma even to refer to psychiatry. Many medical professionals do not want to refer to psychiatry, especially because I worked in palliative care. The oncologists feel that getting cancer itself is quite stigmatized in our society. So to tell that person, you also have to go to psychiatry means that person will get, a double kind of stigma. So that is why this that concept of distress came in oncology. Rather than saying depression or, having any disorder name like that in psychiatry, the concept of distress came and developed a pathway for distress. But I think what we did also in palliative care is that what we do is we train a few persons who are inclined to look into mental health issues in your team. Like, not everyone will be keen. So it could be of any discipline, like nurse or social worker or endocrinologist, whoever it is, a core group from each specialty, three or four people, we can train them. And then they can be within your team itself to look at the primary level of, so to identify, to even give the primary care kind of supportive counseling and all those things, and only refer or call one of us. So what we do in palliative care, like how I have worked is, I always sit with oncology and palliative care. I don't ask people to come to me, so I go there. So if you have people, then we should have a way where we can come and then provide. So the primary concern is for the person. So we should not look into the logistics of it. We should train a core team within each department who are inclined and interested to offer care. So then that team will take care of the primary essential issues, and then we can chip in when it becomes complex or complicated. I think that has been effective in palliative care.
Morning, ma'am. Thank you so much for your presentation. I just want to go back to the alcoholism and substance abuse conversation that we had. I always feel that we address curative care from the preventive aspect, because I feel alcoholism and substance abuse are a result of unaddressed development. And what can we do in order to be able to focus a little more on preventive care so that we can contain this kind of curative support that is on the rise?
Is this specific for substance use that you're talking, or for generally mental?
Generally in society, when we say that within Kerala we have such a high number, I also feel that in the course of the way our state has developed, I feel that we've always ended up being...
Talking about cure.
Yes.
Yeah, I agree. I mean, of course, medicine as such has preventative, like community medicine and primary and secondary level of prevention is always there. But I understand what you mean. So I think that the only way is to slowly, I mean, it's not going to be quick. There's no fast one-stop miracle for that, but it's to be interventions in the community. So you have constant conversations, open conversations at various levels, including schools, where the youth is also addressed from a young age to show them. And I think values are also very important, that you instill values. So whatever, even in schools, education has become, like Sir said, it's all about success and wealth creation, even in terms of education, isn't it? So how do we instill back values? So I think values should be instilled in all streams, including our medical education, so that people understand that it's not about becoming a doctor who's successful, like working in a big hospital or anything also, but rooted in values in terms of compassion and empathy, being honest, having integrity. So that those kind of values when instilled from, so it'll be a very long process that you catch them young and then you nurture them. And like Jaico said that, stress affects from the embryo level. So when you start young and nurture them, probably we can look forward to a much more positive and healthy future. There is no solution for what you asked.
Thank you everyone for a very participatory session for this World Mental Health Day special session. We'll see next Thursday at 8 o'clock. Thank you all.
Thank you so much.